So we're going to get into the muscle relaxers. Sometimes you can see them being labeled as spasmolytics. We're going to talk just only about two of these drugs because these are the two that are most commonly used. There's a few more out there. We'll talk about more of them probably in the CNS lecture series next module. So the first one is cyclobenzaprine or Flexural, the brand name. Of course, you don't need to know brand names. I put brand names on there just so that there's some clinical overlap. A lot of your patients won't be able to say, and a lot of your nursing staff may not want to say cyclobenzaprine, so they may just call it Flexural. Sometimes it's mispronounced Flexural, but it's spelled Flexural. Mechanistically, it has a couple of mechanisms. First, it's going to increase norepinephrine release from the locus coeruleus. Okay, and it's okay that you don't know what that is yet. And by way, it'll inhibit alpha motor neuron activity in the ventral horn within the spinal column, within the spinal cord. There are, of course, anti-muscarinic effects, and these are pretty much undesirable. They can produce sedation, confusion, hallucinations, abnormal dreams in some patients, dizziness, as well as there's going to be some GI effects coming from the muscarinic receptors. Also vertigo, less commonly encountered. So those are the main kind of side effects. And it's okay if you don't really understand how that's going to work, but I just want you to know what the mechanism is. The other spasmolytic drug is tizanidine, and mechanistically, this is an alpha-2 agonist. We're going to spend some time on this because this is the first time, at least from the pharmacology side, that you've seen alpha-2 agonists being used, and I want to show you what that looks like. So that offers both pre- and post-synaptic receptor inhibition. And so we're talking about the pre- and post-synaptic adrenergic receptors, of which we're talking about including alpha-2, alpha-1, beta-1, beta-2. Okay. So the side effects are going to be pretty unpleasant: drowsiness, hypotension, dry mouth, and asthenia. All right. And so I want to spend a little bit of time looking at the alpha-2 receptor. Okay. And so typically, when we talk about the alpha-2 receptor, we're talking about a G protein coupled receptor shown here. And this is mostly on the pre-junctional neuron. Okay, there's very few post-junctional alpha-2 receptors. Most of the post-junctional receptors are either your beta-1, beta-2, or alpha-1. Okay, and now here's the neuron. Here's a noradrenergic neuron secreting. These are the vesicles. Then those vesicles are the precursors to norepinephrine. Once norepinephrine is made, it gets released at these synapse here in the plasma membrane binding with this receptor, with this vacuole. And so here you see norepinephrine being released in the synapse. And of course, norepinephrine can bind to beta-1, alpha-1, beta-2 with varying affinities. Okay. But one thing I do want you to understand is that the alpha-2 receptor has a little bit different kind of physiology. Okay, and that's because it's a negative feedback loop. Excuse me. And so if we look at the norepinephrine binding to this alpha-2 receptor, we can see some changes upstream within these vesicles. Okay, and so what this does is this acts as a negative feedback loop, and when norepinephrine is bound to this alpha-2 receptor, it shuts down norepinephrine synthesis and secretion. Okay, so what does this mean? You get very little to no norepinephrine being released postsynaptically, and very little to no norepinephrine being released here. Okay, it would all just depend on what was released before that drug was bound. All right, and so just to kind of summarize, the alpha-2 receptor is sometimes called an autoreceptor, and when you agonize it, it instills a negative feedback loop, which we just described, okay, and basically has the opposite effect in terms of the response. And so when you supply an agonist, okay, there's going to be less norepinephrine in the synapse because of the negative inhibitory feedback. And when you supply an antagonist, there's going to be more norepinephrine in the synapse. Okay, and that's because the normal biology of this alpha-2 autoreceptor binds to the excess norepinephrine that's sitting within this synapse. Okay, and so when the concentration of norepinephrine is high, this activity is this neurotransmitter binds to the alpha receptor and tells this neuron to stop secreting and producing and secreting norepinephrine. Okay, so that's kind of a key concept here that I wanted to kind of drive home. This is kind of a newer thing that we haven't really talked about. Okay, so let's end this here, and we will continue with the next drug class.